Random skill stations focus on isolated injuries or conditions and grant you the fact that the scene is safe. The long bone fracture immobilization station is designed to evaluate your ability to immobilize a non-angulated, closed, long bone fracture using a rigid splint. You may be presented with a fracture of the radius, ulna, humerus, tibia, or fibula. You will have 5 minutes to complete this skill.
I have gloves on. My partner is going to hold manual stabilization of his forearm. Does he have a distal pulse?
Yes, he does.
Is capillary flow less than 2 seconds?
It is.
Is he able to move his fingers and squeeze my hand?
Yes, he is.
Okay. And is he able to feel my fingers?
He does.
Okay. I'm just going to use a padded board splint to initially immobilize the arm. I'm going to put the hand in a position of function. There's really no gaps in there to fill into. I'll just use the roll of cling to immobilize. Is the fracture mid-shaft?
It is.
The progression of this station is to take or verbalize infection control precautions, direct application of manual stabilization, assess motor and sensory functions, and distal circulation. Measure the splint and apply it. Joints above and below the fracture must be immobilized. After completing the application of the splint, the candidate reassessed motor and sensory functions and distal circulation. He then secured the arm to the trunk with the sling and swath. The hand had already been immobilized in the position of function. Finally, after applying the sling and swath, he completed the station by reassessing motor and sensory functions and distal circulation. The next station that we will review is traction splinting. This station is designed to evaluate your ability to immobilize a closed, non-angulated mid-shaft femur fracture using a traction splint. You have 10 minutes to complete this station.
At this time, I'll get my assistant to come over and add some gentle inline traction.
The principal steps of traction splinting are to direct manual stabilization of the leg and to apply gentle manual traction. Assess motor and sensory functions and distal circulation.
Sir, can you feel me touching your foot down here? Yes, I can. Both sides.
You can adjust the splint to the proper length by placing it next to the uninjured leg. Remember, the splint should extend from the ischial tuberosity to 6 to 10 inches beyond the foot.
My straps.
When the splint is placed next to the injured leg, remember to prepare and position the straps. Be sure that a strap will not go over the knee or the fracture. Position the splint beneath the injured leg. Secure the ischial strap first.
Slide this up in place.
Next, apply the ankle hitch as the assistant maintains gentle traction and connect it to the end of the splint. Apply mechanical traction until it provides relief to the patient. Finalize the position of and secure the support straps. Re-evaluate the proximal and distal securing devices.
Secure.
Reassess motor and sensory functions and distal circulation.
Down here.
To complete the station, you will verbalize the securing of the torso to the longboard to immobilize the hip, and securing the splint to the longboard to prevent movement of the splint. To assure successful completion of this station, remember to take or verbalize infection control precautions. Prevent the loss of traction at any point after it is assumed. Assess motor and sensory functions and distal circulation before and after splinting. Prevent excessive rotation or extension of the foot after splinting. Be sure to secure the ischial strap before taking mechanical traction. Finally, the final immobilization must support the femur and prevent rotation of the injured leg. The next station